Women with pituitary tumors can't get pregnant.
No, in fact, the pregnancy rates are very good with this.
Weight gain or tiredness always means a hormone tumor.
No, there are multiple reasons
Other reasons for weight gain.
Weight gain. Rates of patients name where they have gone back to their usual normal life functioning and having proper life balance. And there is a very interesting pattern because of this crossing. You lose vision on the side of your eyes, so your visual field, like we have a very wide visual field, goes on becoming slowly narrowing. And patients do come with interesting history, like I turned left and I bumped into somebody. So visual disturbance is one thing which you should keep in mind, that it may not be related just your eyesight, eyeball, and it may be related to something inside the brain. Endoscopic pituitary surgery. Unfortunately, there are few cases where you have to open skull when the tumor is going behind or laterally, especially causing mass effect. And usually these are elective surgeries.
So how does the post-surgery recovery looks like?
We have treated almost 3.5 centimeter big, like bigger than lemon, tumor with a drug which suppresses prolactin.
So that's the largest size of pituitary gland tumor?
No, we have operated more than 4.5 centimeters also.
In today's episode, we turn our focus to a small but mighty part of the brain, the pituitary gland. Often called the master gland, the pituitary regulates vital hormones that control everything from growth to metabolism to reproductive health. But what happens when this tiny gland develops a tumor? How do these tumors impact the body and the other treatment options, risk factors? Joining us today is Dr. Ranjit Deshmukh, a distinguished consultant neurosurgeon known for expertise in complex cranial and spinal surgeries. With over 25 years of experience, Dr. Deshmukh brings a profound expertise across multiple neurosurgical subspecialties, including skull base, endoscopic, functional, and stereotactic procedures, earning him recognition on both national and international platforms. So, let's get this conversation started. Hello and welcome to Sahyadri Health Talks. I'm Dr. Tushita, and today we have with us Dr. Ranjit Deshmukh. Hello sir, how are you?
Fine, thank you. Good afternoon.
How does it feel to be on this podcast? I know I have taken a lot of time of yours for this, and it was very difficult for me to pull you out of the OT.
Yeah, not very used to such kind of things.
But then we really wanted to have a discussion with you on today's topic, which is pituitary tumors, because as the last time when I had a conversation with you, you were saying that almost every third case of brain tumor that you see is pituitary gland tumor.
Yeah, incidence wise it's a very common
thing. But everything gets tagged under the bigger umbrella of brain tumor. So let's discuss about pituitary gland tumor today. But before we go in depth about pituitary gland tumor, help us understand what is pituitary gland and this fancy term, which is the master gland. Why is it called as the master gland?
First I would like to say that when you hear the term pituitary tumor and you correlate with brain tumor, it is a brain tumor, but this has one of the best prognosis in brain tumor compared to other tumors like glioma. Most of pituitary tumor patients, they do very well, and they have very good life expectancy with good life quality. So don't be scared of pituitary tumors. That's what I would like to state first.
State out the message.
Coming to master gland, yeah, it is the master gland. In a lot of cultures, there is a lot of mysticism about pineal gland. Shankar ki tisri aankh, third eye, and all, but pineal gland actually has very little work, and this pituitary gland has a lot of work. So I would first like to talk about hormones. So there are two types of secretions the glands make, or glands, like sweat gland, salivary gland, glands in your gut, like pancreas. They secrete their secretions out of the gland, out of the body. Like gut is also out of the body, and then they do their work locally. Like you chew food with saliva, and locally it helps to digest. So these are called exocrine gland. So apart from that, there are glands which are sometimes very small, sometimes large, like thyroid. Those are hidden and they don't secrete their secretions locally. They secrete their secretions into the blood. Through the blood, it spreads to different organs, either target organs or whole of the body, and then they bring their effect. It's like a messenger, sending a messenger to a targeted cell or sending a messenger to different cells.
So it basically travels through blood and reaches.
Through blood and reaches different organs or cells or their targets. And most of these glands or all of these glands are controlled by pituitary gland. That's why it is called
the master gland.
Master gland.
But it's a tiny one, right?
It's a really tiny one. So brain volume on an average is like a kilogram and 300 grams. This gland is less than 1 gram. Usually 6.6 grams, 0.8 grams. It is less than 1 centimeter. It sits in a very well protected place of itself at the base of the brain. And it's like specially made place. It's called sella turcica. It means like horse saddle. Actually that meaning turcica means turkey. So Turkish warriors used to sit on that concave thing, and from there that term has come. And that tiny 1 centimeter place hosts this gland in the center of your skull, in the base of the brain. So it's really difficult to reach area, and that controls almost all of your endocrine glands and all of your hormones. So that's why it is called master gland.
Master gland. So when it comes to this master gland tumors, right? So usually there is an apprehension that the moment we hear the word tumor, it's a very big myth that all tumors are cancerous or tumor hai to matlab cancer hai. So tell us about it. What's with this pituitary gland tumor, and are all of them cancerous?
No, actually. Out of all brain tumors, meningioma and pituitary tumors, these are two second and third commonest tumors. Those are mostly non-cancers. In my 30-year career, I have seen only 2 cancerous pituitary tumors.
Only 2? Only
2. So like we operate maybe 3-4 per month, and over 30 years I have seen only 2. So it's a very negligible thing. So that is another good thing. Why I said the prognosis is good, because they are non-cancerous. So you can deal with them, and you can have good results, and like they won't spread anywhere else.
Yeah, so the line of treatment becomes more effective.
Yeah, so treatments are more effective. So when you hear pituitary tumor, just brush off that it would be cancerous. Just think that it is a non-cancerous tumor.
Okay. So what are the typical symptoms of this pituitary tumors? Are they symptomatic?
So so as I told you, they are very common tumors. That I told by presentation, like when we try to treat patients, when we try to operate or do some surgery or radiation or anything. Actually, pituitary tumors are much more common than that. So if you go by autopsy studies, like patient died, individuals, not patients, died of irrespective of the cause, like not because
for
of
any reason,
tumor, for any reason, and go by autopsy studies, almost 15-20% of the deaths, they
the autopsy reports will show.
Yeah, autopsy report will show a smaller or larger pituitary tumor. And nowadays we undergo MRI for various reasons, like trauma, some other cause, headaches and all, and we see a lot of small pituitary tumors.
Doesn't it make it more risky that in such scenarios, the pituitary tumors being so asymptomatic will get diagnosed at a much later stage? Isn't it a cause of worry?
So let us go back to the presentation then. So we divide this presentation into 3 groups. As we know that this is master gland and the main work is secretion of hormones. So the hormonal secretion can go up, producing hyperfunction of some of the hormone that it is secreting, or because of the stress pressure on the gland itself, the secretion can go down and produce hypofunction. So those symptoms usually general physicians they catch, like this looks like the said condition, and then patient undergoes hormonal assay, and then tumors are found. So one of the main function of, all the hormones are controlled by it, but menstruation, pregnancy, all those hormones necessary for control of these female functions, those are from pituitary. And the disturbance in that period, like in fertile age from 15 to 45 or 55, any menstrual disturbance can indicate that something is wrong with pituitary.
Acha.
So women should not immediately rush for MRI or anything. Usually gynecologists know that. They do conduct a test unexplained cases like amenorrhea, not responding to usual treatment. They do a test called as prolactin, which is a hormone
Secreted by the
from
pituitary
and they come to know if prolactin level is high, then send for MRI. So it's a step by process. Like one menstrual irregularity and you rush for MRI, that's not the situation, because pituitary tumors are in general population very rare.
Okay.
Although in our practice they are common, as such brain tumors are not very common thing. They are rare thing, not like heart attack or other tumors,
not diabetes.
breast tumors, not diabetes, or even breast tumors or colonic tumors or other tumors. So it's a rare entity, so people should not just immediately rush. I mean, that's a worry we have after any informative article or podcast.
That
everybody
start
panicking,
yeah.
abhi MRI karna chahiye.
Yeah.
So it's not like that. Go to your doctor, gynecologist, general practitioner, and he will know when and what to advise.
So one of this
one
is
set.
Yeah.
Another set is if the tumor is non-secretory, it doesn't secrete any hormone, because there are a lot of cells, supportive cells or non-secretory cells. Those also produce tumor, and in fact those are more common than secretory tumors. And then they keep on growing, and because they grow very slow, they don't produce immediate mass effect effects because of their pressure, like headaches, vomiting, things like that, which we associate with brain tumor. So what happens that gland goes on enlarging, the tumor comes out of that small place in the skull and expands upwards, because downwards is bone and on side is also a tight compartment called as sinus.
Less movements.
Less movement. So the only supple or easier way is to go upwards, and they grow upwards. And what is upwards? The nerves which give you vision. So from your eyeball, two nerves go, they join each other, cross, and then they again go back. That is called as crossing or chiasma. And that chiasma is just above the pituitary gland. So
that's
when
where the
tumor
impact
grows
comes.
and it starts pressing on the chiasma, and majority of the patients who have large tumors called as macroadenoma, they are usually presenting with visual complaints, and there is specific pattern of that visual complaints which usually ophthalmologists speak, and sometimes if patient comes to us directly, we pick it up.
So you're saying that typically these cases, I mean, so if I have to ask you that, what would be the red flags a person should look out for? So one of those red flags can be sudden disruption or disturbance in vision.
So usually it is not sudden. Usually it is very slow, subtle, and gradually
so slow and subtle issues with the vision.
There is a very interesting pattern. Because of this crossing, you lose vision on the side of your eyes. So your visual field, like we have a very wide visual field, goes on becoming slowly narrowing. And patients do come with interesting history, like I turned left and I bumped into somebody, because he just doesn't notice that somebody is there.
This side of the vision itself is missing.
On either side it can happen. So that is a very common history. Like I bumped on something and I didn't know why he is there. And then he goes to ophthalmologist and notices. Few people do notice that my distant vision is failing, or I have some eye strain, or I think something is wrong with my vision. Few people do come to us or to the ophthalmologist or neurologist with this complaint. But this interesting thing can happen. So visual disturbance is one thing which you should keep in mind, that it may not be related just your eyesight, eyeball, and it may be related to something inside the
also.
brain.
Yeah. So we have spoken about the role or the impact of pituitary gland tumor on vision. So help us understand that where all this tumor also causes other issues, and what should be the thing. Is it hereditary?
There are described syndromes of hereditary pituitary tumor, but those are extremely rare. Like I haven't seen a single in 30 years.
Achha. So so if there's somebody who has pituitary gland tumor in the family, so it's not like that.
So general screening for his kids or his sons, daughters is not recommended. Not at all recommended. It's usually it's a sporadic, something called a sporadic thing. Like it happens in say 10-15 people per 1 lakh people. That is what the usual occurrence or incidence is.
So, what are the key imaging or the blood tests which are involved in detecting
So there are
this?
two kind of imaging. One is imaging of the brain. Till it used to be CT scan, and now MRI is the gold standard, which shows all these structures like with minute detail. You can imagine, you can do imaging of minute like a grain inside the pituitary gland, which is less than a centimeter, and you can imagine itself inside the gland also. So MRI is the gold standard right now, but CT scan also plays a very important role when you plan for the surgery. So how big the cell is, how wide it is, from where to approach, and all that. But usually MRI is the imaging which is done. Second part, very important, is hormonal assay. First of all, for us to understand whether this is a secretory tumor or not, then which hormones are secreted more, which of them, which hormones are suppressed, and like do we need to give supplements beforehand, or do we need to sort of suppress any hormone which is produced in excess for that. So all that we need to understand beforehand. So there are a lot of blood tests which directly measure pituitary hormones or measure the hormones of the target glands. Like pituitary gives stimulation for thyroid gland. So many times we need to assay the thyroid glands. Pituitary gives stimulus to male sexual hormones, testosterone, secreted in testes, and we need to measure that level. And sometimes we need to give injection or supplements for that, for female hormones also. So these all things are done once we diagnose pituitary tumor. Now there is something called as microadenoma. Those are less than 5 millimeter. Actually, by definition, less than 10 millimeters, so less than a centimeter. But many times they are very small tumors which are not easily caught on radiology because of artifacts or something. So there are series of blood tests that you need to do to understand, yes, this is the hormone being produced, and the reason for this hormone being produced in excess is in pituitary. For example, so there is something called as Cushing's disease. It's a very famous and quite common disease where steroids coming from your adrenal gland above the kidneys is produced in excess. But the reason is not usually there. The reason is usually in the pituitary, where the hormone which stimulates this steroid production is produced in excess. So then you have to prove, because there are other diseases also. A particular type of lung cancer produces the same hormone. It's called ACTH. It stimulates the kidneys. Or sometimes you have tumor in the kidneys. On imaging, it looks of same size because it just needs to work a little more. And a small grain-like tumor in pituitary can produce havoc on your metabolism.
So when we hear about this pituitary tumor, a few very common terms which are used is functional, non-functional tumors. Are these, very different from each other? And
so as we told, there is a certain set of tumors which secrete the hormones. These are secretory or functional tumors. And then there are other tumors, majority of the tumors, which either do not secrete hormones or they secrete in such a minute quantity that they are called null cell tumors. So secretion is not an issue with that. Those are called non-functional or non-secretory tumors.
Okay. So while I was having a conversation with you before we started the podcast, I remember you, mentioning about a very interesting story, which was that there are so many thousands of skulls kept in a particular.
So Hunterian Museum.
Yeah, Hunterian Museum. Tell us about that.
1300, I think.
So
there was I think Bailey's his name was, a person who was a giant. So that is because of excess secretion of growth hormone. Like when we grow, we need that hormone. So if that hormone is lacking, the candidates are retarded and very small. And if it is more in before you gain puberty, then you have giants. And if the hormone is secreted after that, like after adulthood, then you have something called as acromegaly, where the growth doesn't increase, but the facial features, hands, and they become all thick, like muscular, like cheekbones become gross, and it looks a very different, typical look. Like you see that patient and you won't forget it for life. So there was a person who was giant, and as there was no treatment available, the life expectancy was very less. He was a learned man, and this fellow who had this museum, he wanted this person's uh, skull and bones for his museum. This person knew that he's after the death.
Yes.
So he went lengths to avoid that, like
Acha.
legal this thing and that thing. But in spite of that, after his death, this doctor persuaded the authorities that this is such an important specimen for the museum,
Yeah.
and he got it, and it's still in that museum.
It's still in that museum. So much of studies and
Yeah, actually,
research has gone.
if you go in medical history, the research which has gone into discovering hormones is one of the fascinating stories, like detective stories. I can give you 2-3 examples. Like previously, opera singers, many of them used to be castrated, especially in Vienna,
Acha.
because before puberty, so that their delicate voice could be maintained. And then those people, doctors used to study on those people and used to wonder why it is happening. But nobody knew that exactly why testis is doing that. There is a very famous Parisian, I think, doctor, Brownseeker he is called. There is a syndrome of spinal cord transaction on his name. So he one day announced in his 70s that he took a concoction of blood from testicular vein, semen and extract of testis, injected in himself, and he told in a press conference that now he is feeling much better, with much vigor and all. It may or may not be true, but then there was a frenzy in Europe for almost 20 years that people started doing the same thing from sheep, monkey, whatever, injecting. Doctors started prescribing, and then they turn out to be there is not much effect. But in a similar way, there's a father of neurosurgery. He has a lot of inventions in neurosurgery, Victor Hosley. He was an army general or doctor. So he has done experiments on thyroid. And he and his student Oliver, they produce extract of thyroid, and with that they treated something called as myxedema, when the thyroid hormone is less, or cretinism. And without understanding that it is because of hormone, this just concoction or that thyroid juice, they started giving to these children or kids or patients, and they did better. So thyroid hormone was not discovered. I mean, hormone term was not even known for them. In mid of 18th century, there was a doctor or some animal husbandry person who castrated cocks. Saw that how their health went down and how they behaved. Then he implanted those testes, and he saw that they are again becoming better. But his discovery was just lost, like Mendel's discovery in genetics. And after many years, another person was there who castrated and implanted those testes in a different place. And he did autopsy and found out that there are blood vessels on these testes. And then he postulated that probably they secrete something into the blood, goes in the blood, and it doesn't directly travel through nerves or the substance, something. And then Sterling, from some, I think, Greek mythology, gave this name hormone. So the discovery is very fascinating of the hormones. Everybody knows the story of insulin, Banting and Best, two American-Canadian scientists, how they fought and how they discovered insulin, and they sort of prevented death in something called as insulin-dependent diabetes, which takes occurs in very young kids, and death was certain because of diabetic coma. So that was in 1930s, I think. So these are all fascinating stories. And actually, to give you the perspective, like when we measure sugar, it's like milligram per decibel. So 120 by 100, what we say, 120 per 100 ml. So that's a huge amount. Thyroid hormone or insulin is secreted in microgram, a little less, like you divide milligram by 10, it's like 10,000 part. Pituitary hormones are secreted in such minute quantities, it's like 1 billionth part of gram. So to extract that or to test in blood, you take 5 ml of blood and you measure the growth hormone level or prolactin level. It's such a, what you can say, feast of science, that such a minute quantity you have to develop a test to find that substance in a minute quantity. And all this is like, all these stories are like detective stories. How somebody reached there. Like for a growth hormone, controlling hormone. So even if pituitary is master gland, there is something called as hypothalamus, a part of brain, which secretes substance in even minute quantities,
Acha.
even minutest quantities, and those are extracted in 50s and 60s by people by literally collecting thousands of glands, thousands of brain samples, crushing it, isolating the substance, and getting to the exact substance that they think
Because the
is
production
useful.
is so less.
It's so minute
So
production.
minute production.
So it's a very fascinating
Yes,
story
indeed,
if you get into the history.
indeed. It was very fascinating when you told me for the first time. So now coming back to the pituitary gland tumor surgeries, we have discussed about the risk factors, the diagnosis. Now coming to the last part, which is the surgery. So typically, how is this pituitary gland surgery done?
So almost-
Take us through it. I'll tell you why I'm asking you this, because being a brain tumor, there is a common conception in everybody's mind that every brain tumor needs a open skull procedure, or maybe a hole will be done from the skull, shaving of hair, which is not true in case of pituitary gland tumors.
Yes.
So how does it go?
Very few pituitary tumors need skull opening
Acha.
because of their location, specific location, which is at the base of the skull. So you imagine that it's a two-story building and there is something on the upper floor. So rather than breaking the walls, if you make a small hole and reach that particular point, you can get it.
Yes.
My professor always used to tell a story of an English movie, Hollywood movie,
Acha.
some bank robbery, like how they
Acha.
tunneled below it and
Below
just
it.
took out the locker rather than breaking all the defenses of the bank. Some great bank robbery, something
Acha,
like
acha.
that. So it's like doing that. So you
Acha.
go through base of the skull,
Acha.
and roof of the nose is base of the skull. So
Acha.
that they share a very small area in the center. It's called sphenoid sinus. So you go through that sinus, and above that sinus is that concavity where the pituitary gland is hosted, and the tumor arises from there. So fortunately, usually the tumor little bit makes it more concave, makes it a little more expanded, and then you can reach that area with fair precision. So most of the tumors which are in that sella, in that area of the pituitary, and those who grow linear upwards, maybe a little here and there, you can target through that. So there is no skull cutting opening for majority of the tumors. Yeah, few tumors which are very big, which you don't reach through nose, then you have to sometimes do open surgery, but that is very rare. There are two reasons for that. First of all, diagnosis is becoming more and more easy. Availability of CT scan,
CT and
MRI,
yes.
overall perception of patients, or perception, not perceptions, the early diagnosis and thinking process. So usually we catch them
at a much
when they are
precise
at a
place.
precise place. Blood tests are available, so hormonal assays are done more frequently. And actually the pituitary surgery 100 years ago, it started with opening skull. And usually tumors used to be big because there was no imaging. People used to just on clinical symptoms think and decide.
And expertise.
This patient might have pituitary tumor. So what is the way to do?
Open and
see.
check.
Open and check. And many times because of not developed techniques or instruments, there was no microscope, unavailability of microscope and instruments. Many times reaching there used to be difficult, and people have to abandon that. So Hosle was the first one who operated on 10 consecutive patients, and 8 of them survived, which itself that time was a very difficult task. Like you operate and many patients just die because of surgery. Then Cushing is the person, Harvey Cushing is called father of neurosurgery, is the person who dedicated majority of his time, or a big portion of his time, studying pituitary, studying effects, studying the hormones, and developing surgeries for that. So he was one of the few who developed this approach through nose, and then he abandoned because there was no sufficient armamentarium. And few decades later, his students are basically French school, it is called French Canadian school. One Dr. Hardy is there, Jules Hardy. He may be still alive. He is based in Montreal. So he developed a particular system, started using microscope, and still we use that Hardy speculum. So you put it, you make a small cut in the septum of your nose, you go on dissecting along the septum, and you put a particular type of retractor which just separates the blade by 1 centimeter. And you operate through that tunnel looking through microscope. So it involves illumination. So you have light at the depth, magnification. Through microscope you expand it so that you see the structures very well. So he was the one who started studying the inside structure of pituitary in operation theatre and started removing microadenoma. Till that time, acromegaly or Cushing's disease, like you cut off the pituitary and then try to give supplements to the patient, hormonal supplements to the patient. So he was one of the pioneer in that. There were people who had tried using endoscope in the 60s, but it didn't become commonplace. Basically because the endoscope were large and techniques were not developed. But since 90s, the endoscopic surgery developed more and more. And we started that program around 12 years ago. And last 10 years maybe, most of the surgeries we do endoscopically. So what is the advantage? It's like through the hardy speculum you have a tunnel and you look through the tunnel. You magnify it. But with endoscope you have end-on vision. So you put your eye inside the tumor or near the tumor, and you see around, and you have better control over the system. You have better magnification. You have imaging which goes on left and right. It's not a tunnel vision.
View.
One anatomical detail I forgot to tell. It is surrounded by many vital structures. For example, these arteries which supply most of your brain, they are just next to your pituitary in a serpentine and unpredictable course. Sometimes they come very close, sometimes they pop over. So you need to study that also. And that visualization is better with endoscope. When you are in tunnel, you try to sort of pull out things, and that can be dangerous. Then just above the pituitary are your visual nerves. Then there are a lot of veins. Then there is a very delicate area called hypothalamus. Is just above that. So all these structures are touch me not. Absolutely touch me not. Rest of the brain you can, sometimes we cut brain to get into tumor or in the tumor. But these areas are absolutely touch me not areas. So those safety things increase with endoscopy. Endoscopic pituitary surgery. Unfortunately, there are few cases where you have to open skull when the tumor is going behind or laterally, especially causing mass effect. And usually these are elective surgeries. So we study the MRI, hormonal structures very well. For this endonasal surgery, we definitely do CT scan to understand bony structures, because we have to remove bony structure part by part, and hormonal assess also. A very minority of tumors present, pituitary tumors present as emergency. There is something called as pituitary apoplexy. It is less than 5-10% in tumors. When the tumor grows rapidly, or maybe it grows and the blood supply doesn't suffice. So there is a infarct, death of some part of tumor, and then it suddenly swells up or bleeds. And those patients have sometimes very stormy presentation, headache, vomiting, unconsciousness, the eye nerves suddenly become big, squint and all, and there is a very big metabolic storm also. The sodium drops and rest of the hormonal control is lost, and these patients sometimes need emergency surgery or at least ICU management. But otherwise it's a elective procedure. You can definitely think about it, plan it well, and decide like that.
So how does the post-surgery recovery looks like, especially considering that pituitary gland is something that monitors and regulates so many things, including the fertility aspect, the sexual health. So how is the impact of pituitary gland tumor surgery on these aspects?
So basically, it depends again on presentation, whether it's secretory or not secretory. The commonest of secretory tumor is prolactinoma, and now almost no prolactinoma is surgery. We have treated almost 3.5 centimeter big, like bigger than lemon tumor, with a drug which suppresses prolactin.
So that's the largest size of pituitary gland tumor?
No, we have operated more than 4.5 centimeters also, which is like an egg or bigger than that. I'm telling about prolactinoma, a specific type of secretory pituitary tumor, which in current medical does not need or very rarely needs surgery. So it can be treated only with medication. So that medication suppresses pituitary hormone, prolactin hormone. Tumor also shrinks, and effects of that prolactin secretion, they also go down. So surgery is out for that. But there are next to common secretory tumors. One I told acromegaly, where growth hormone is very high, and second is Cushing's, where steroids are produced in enormous amount. These two need very meticulous surgery. Sometimes if you leave a small part of tumor, you have to again go and visit and remove that, because there is no good medical treatment available for suppressing those hormones. So those surgeries have to be meticulous, and in those cases you have to have a complete tumor excision. Apart from that, other non-secretory, sometimes even if you leave some part of tumor, we just observe them over period. If again starts growing, you can decide whether to take it out again or give radiation. And with endoscopic surgery, we are proud to say that we are achieving better resections and more complete resections of all kind of tumors. So that is a big advantage in our practice in last 10-12 years. So usually the recovery of pituitary surgery, recovery from pituitary surgery, either transcranial or through the nose, is fairly smooth. There is a little discomfort period of 2-3 days when we pack the nose, because you cannot put sutures deep inside the nose.
Correct.
So those wounds which we make there, we just pack with some material, and that we remove after 3rd day. So during that period, patient has to breathe through mouth. And usually if surgery, and it goes mostly without any uneventful incidences, the patient is awakened immediately after the surgery, kept in a day or two in ICU just to look for if there is excess bleeding, hormonal storms or something. And there is little nasal discomfort for a few weeks to months, like crustaceans, those blood clots falling or getting into this thing. And that's all about it. There is a particular interesting thing. So posterior part of pituitary secretes a hormone which regulates amount of urine your kidneys make.
And posterior part of the pituitary.
Posterior part of this anterior and posterior part, we didn't mention that. So that hormone usually after extensive tumor removal gets disturbed for a while. So patient keep on producing a large amount of urine. And previously in the 90s when I started my neurosurgery career, good replacement were not available. So we used to literally keep jugs of water and give saline, liters of saline,
so that the patient doesn't get dehydrated
and
balance is maintained.
Sodium from getting up. But now that hormone called vasopressin, it's available even in tablet form, injection form, puffs form, and usually we control it very well. And in most of the cases, it comes back to normal within months. And visual recovery usually starts very soon if the patient has presented with visual symptoms, and improves as per the case. Hormonal assay we have to keep on doing regularly, hyper, hypo or what, and sometimes we need to revisit the surgery if it's a secretory tumor, and we need to give supplements, hormonal supplements for long. It's like taking insulin every day. So hormonal supplements are usually every day except for testosterone, which is once a month injection. It's a depot preparation. So these are the recovery post-surgery.
That's about pituitary gland tumor. Now moving on to the next segment, I have a few myth busters. I'll read out those, and you can tell us if it's a myth or fact. Few of these, or maybe I can say most of these, we have already discussed, but still if you can just say a few lines on this. Okay, so the first one is pituitary tumors are brain tumors and are always dangerous.
No, I mean any tumor can be dangerous, but as we discussed, pituitary tumors, most of them carry very good prognosis.
Because they are most of the time non-cancerous.
They are benign, non-cancerous, and although in very difficult area, we have very good armamentarium, either medical or surgical or radiation or otherwise to control that.
If you have pituitary tumor, you will always lose your vision.
No, rarely patients do present that the vision is gone beyond repair, and then the recovery is very poor, but those are very rare cases.
All pituitary tumors need surgery.
No, in fact, pituitary tumors, as we told in autopsy findings, are so common, and nowadays every Tom, Dick and Harry advises MRI for some simple headaches or some migraine and all. So these a lot of tumors are diagnosed. Like I may be seeing 4 or 5 patients per month who come with MRI report or scan pituitary tumor, क्या करना है? And these are called incidentomas. So actually the symptoms, patient symptoms are not because of the tumor. You do scan for something else and you find a tumor. Incidental tumors.
Yeah.
So in those cases, most of them need just observation unless they produce some hormonal secretion or they start pressing on your optic nerve or some other symptoms. Otherwise, we just follow them. Sometimes they start growing and then we operate. I typically have evidence of at least substantial growth before operating. Like a very old patient coming with pituitary tumor, patient outlives the tumor growth. But young patients, there is more potential of growth. Then sometimes you have to do that. But usually we do scan after 6 months, 1 year. You can do visual testing, something called as perimetry, where even a slightest affection of vision, compression, you diagnose clinically and then you plan surgery. So not all pituitary tumors need surgery.
Okay. Once removed, pituitary tumors never come back.
No, it's a myth. Like it's a tumor arising from the gland. So even small cells are left, they can grow back.
Okay. Weight gain or tiredness always means a hormone tumor.
No, there are multiple reasons for
other reasons for weight gain.
Reasons for weight gain and tiredness.
Women with pituitary tumors can't get pregnant.
No, in fact, the pregnancy rates are very good with this. They do need treatment. Sometimes you do surgery and take out the pressure so that the normal hormonal secretions increase. But now gynecologists, infertilologists have excellent supplement treatments and fertility rates are very good.
Okay. Blood tests alone can diagnose a pituitary tumor. I think I know the answer.
So we already discussed.
We know the answer. Once diagnosed, life is never the same.
No,
You will
I can give you hundreds of patients' name where they have gone back to their usual normal life functioning and having proper life balance.
Sure. That's about that. And before we, end this today's podcast session, I would request you to share some case of, in your career, which has left a mark in your heart and is maybe very close to your heart. Some case, if you want to discuss with us.
So all cases are very close to heart.
Yes.
There is this one particular patient, I should not tell the name, whom I have operated 3 times, I think. So first he was actually referred by a neurosurgeon. First I operated him when I had not started endoscopic surgery, and a small part of tumor which was behind his artery in a corner had to be left. So I always do post-operative imaging after a certain period, and then I keep a watch on that. So I told him that you have this tumor and maybe we'll need to readdress that. Do scan every 6 months or so, or we'll do radiation. But he disappeared, and then he came with a very huge tumor. He went to some ashram, something like that, and very huge tumor. Which we had to, this was in Corona. So I first operated him maybe in 2013-14, and during Corona period he came with one eye vision lost, another eye just partial vision, and a very huge tumor. So we had to go from above, remove that tumor, majority part of the tumor, and freeze optic nerves and all, and he had some stormy post-operative period. Came out of that, and his sela, that bony this thing, had also become big, and because maybe of my previous surgery, the part of tumor was inaccessible from above. So after 6 months or so, we had to go again through nose, this time endoscopically, and remove majority of the tumor. After that, there was small part of tumor or chunks of tumor which were surrounding the arteries, going in the something called as the cavernous sinus, which we had to radiate. So he underwent all 4 modalities, like a transphenoid surgery, standard microscopic, then an open skull surgery, then an endoscopic surgery and radiation. And from that time, 2020, he is on various hormonal replacement. So he is a complete case study. And he visits every 6 months. Now his sister has taken matters in hand, and she brings him every 6 months. For last 4-5 years, everything is good, stagnant.
So now he is pretty
he is going to his work and all.
Pretty much stable is what we can say. That's about pituitary gland tumor, and thank you so much for joining us. And it was Very, informative, especially
I
those
hope,
stories which you
yeah,
shared.
actually, you can search on net also and
Uh-huh.
documentaries also. There are very fascinating
Yeah, these
stories
are
about
very
that.
fascinating
And
stories.
unfortunately, I mean, we do study history of medicine and we do study history of neurosurgery,
Uh-huh.
but these small stories, they somehow get lost, and not all doctors or not all neurosurgeons know that.
Talk
I
about
somehow
it.
have some interest in history in general and in medicine, so that's always very interesting to discuss those things.
That was amazing to have such in-depth insight on pituitary gland tumor. Thank you so much, sir. We wish you all the best. Thank you for
Thank you.
coming on
Thank you for
Sahyadri Health
calling, and
Talks.
it was fun really.
Thank you.
Thank you.
Signing off, Sahyadri Health Talks.